Amino acids and proteins. So aminoacidopathies, these are amino acid metabolism disorders, which are inherited conditions that disrupt normal amino acid processing in the body. These disorders often lead to accumulation or deficiency of specific amino acids or their metabolites, which can cause various clinical symptoms. So some disorders we have is the phenylketonuria, which is PKU. It is caused by deficiency of the phenylalanine hydroxylase. It leads to accumulation of phenylalanine, which is toxic to the brain. Untreated PKU causes intellectual disability, seizures, and developmental delays. Early diagnosis and dietary management can prevent these complications. Tyrosine anemia is a group of disorders involving the metabolism of tyrosine. It leads to the accumulation of toxic metabolites which affect the liver and the kidney function. Symptoms can include liver failure, neurological problems, and growth retardation. Acalpitonuria is a deficiency of homogenetisase oxidase, which causes buildup of homogenetic acid. It causes darkening of urine and connective tissues and leads to arthritis and heart valve problems in adulthood. And then we have maple syrup urine disease. This is a defect in branched chain alpha keto acid dehydrogenase complex. It causes an accumulation of branched chain amino acids like leucine. It's named for the sweet odor of affected urine of infants. The symptoms include poor feeding, vomiting, lethargy, and neurological damage. Homocystinuria is a deficiency of the cystathionine beta synthase. It leads to elevated homocysteine levels, causing vascular problems and skeletal abnormalities, and it may result in intellectual disability, vision problems, and thromboembolism. Cystinuria is a defect in renal tubular transport, which causes an increase in excretion of cysteine. It leads to recurrent kidney stones due to low solubility of cysteine in the urine. And treatment involves increased hydration and urine alkalization. So diagnosis and management for these is early detection during the newborn screening or targeted biochemical testing. Dietary restrictions, which are going to be tailored to specific amino acid abnormalities, or use of supplements or medications to reduce toxic metabolite buildup, and regular monitoring and supportive care to help prevent some of these complications. So proteins, the basic structure. Proteins are linked polymers of amino acids. Amino acids are connected by peptide bonds which form polypeptide chains. Typical human serum proteins contain 100 to 150 amino acids in each polypeptide chain. So the levels of protein structures, you have your primary structure. That is the linear sequence of amino acids linked by simple peptide bonds. This helps to determine the unique characteristic of each protein. And then we have secondary structure. The polypeptide chain winds or coils into regular structures such as alpha helices or beta sheets. It is stabilized by hydrogen bonding. Tertiary structure, this is the three-dimensional folding of polypeptide chains. The chain twists and folds back onto itself, which helps, or doesn't help, but it creates the functional form of the protein, responsible for the protein's physical and chemical properties. The importance of the structure of the protein determines its function in biological processes. Alterations in the structure can lead to loss of function or the disease. We also have a quaternary structure. It involves two or more polypeptide chains or subunits that are linked together. These subunits can function independently or cooperatively. An example would be like hemoglobin. It's composed of 4 polypeptide chains. Denaturization of proteins. So denaturization refers to the loss of protein's native structure and function. Things that can cause denaturization is heat, hydrolysis by acids, enzymatic action, exposure to urea or other chemicals, and exposure to UV light. Denatured proteins lose their biological activity but can retain their primary structure or their amino acid sequence. Protein charge and electrophoresis. So proteins carry different net electrical charges depending on the pH of the environment. This property allows separation of proteins based on charge through techniques such as electrophoresis. Electrophoresis is a useful method, as we mentioned before, to help quantitate and analyze proteins in the clinical chemistry lab. Protein synthesis. So the origin of plasma proteins. So most plasma proteins are synthesized in the liver. Hepatocytes or liver cells are the primary producers. These proteins are secreted directly into the circulation. And then we have immunoglobulins, also known as antibodies, are a special class of plasma proteins. Unlike most plasma proteins, they are produced by plasma cell, which is a type of white blood cell. Immunoglobulins help play a critical role in the immune defense. Some general functions of proteins is we have tissue nutrition, so proteins play a key role in that, in the nutrition and maintenance of tissues throughout the body. Water distribution, so proteins help regulate water distribution in the body, and that does that by maintaining osmotic pressure. This is vital for fluid balance between blood and tissues. Buffers, proteins can also act as a buffer, and it helps to maintain the body's acid-base balance. They can also act as transportation, so many proteins function as a transport molecule, which can carry substances like oxygen, so think of hemoglobin, lipids, and vitamins in the bloodstream. Antibodies. Proteins include antibodies like immunoglobulins, which are crucial for the immune response in fighting infections. Hormones and receptors. So certain proteins function as hormones and receptors, mediating communication and regulatory processes within the body. Connective tissue. Structural protein like collagen provides strength and support to the connective tissues. Enzymes. Proteins can serve as enzymes as well, which help to catalyze biochemical reactions that we need to live. Hemostasis and coagulation. Proteins are also involved in hemostasis and coagulation, and that helps to prevent excessive bleeding, so we don't bleed out. So albumin. This is the highest concentration plasma protein that we'll find. Our normal range is 3.5 to 5.5 grams per deciliter. The synthesis, it is produced primarily in the liver. To analyze this albumin, we would use the Biuret test, and it measures the peptide bonds in the proteins. We can also do dye binding assays, which is used to quantify albumin specifically. We can also do electrophoresis, which will separate albumin based on the charge and size for that protein. Functions. Maintains osmotic pressure. It's critical for fluid balance between blood vessels and tissues. It can also act as a transporter, which can carry hormones, fatty acids, and drugs throughout the bloodstream. So some clinical significance for this. So if you have a decreased albumin level or hypoalbuminemia, my goodness, you can have malnutrition, muscle wasting disease, liver disease, so impaired synthesis, gastrointestinal protein loss, and renal disease. If you have increased albumin levels or hyperalbuminemia, you can see that mainly in people who are dehydrated, and that's due to hemoconcentration. The globulins, they are a group of plasma proteins that are divided into several different fractions. We have alpha 1, alpha 2, beta, and gamma. So the alpha 1, we have alpha 1 antitrypsin. It is an acute phase reactant, and it functions primarily to neutralize trypsin-like enzymes, which helps to protect tissues from enzymatic damage. So if you have a decreased alpha 1 antitrypsin, this can be associated with severe degenerative lung disease, including emphysema, juvenile hepatic cirrhosis, which is a liver disorder that's seen in children. And then you can do on the flip side where you have an increase in alpha 1 antitrypsin, and this can be seen in people who have an inflammatory reaction, pregnancy, and use of contraceptives. And then we have alpha-1 fetoprotein, or AFP. This is produced in the fetal yolk sac and fetal liver during development. The function of AFP is to protect the fetus by shielding it from the immune attack by the mother. AFP is detectable in the fetus up to 7 to 8 months of gestation. It can cross the placenta and can be measured in maternal blood. So clinical significance, if we have an increased AFP level, it's used as a screening test a lot of times for spina bifida and other neurotube defects. It can also be elevated in tyrosinosis, which is a metabolic disorder. It can also be increased in hemolytic disease of the newborn and people who have a pregnancy with multiples, like twins. You can have a decreased AFP level, and this may indicate an increased risk of Down syndrome. So screening timeline for AFPs, this is usually performed on pregnant patients between 15 and 20 weeks of gestation. Factors that can affect the AFP levels, they can be influenced by the maternal weight. So if the mom has a higher weight, it may lower the AFP level, race, and if the patient has diabetes. AFP results are reported as multiples of the mean. So the normal range is typically between 2 to 5 multiples of the mean. Very high AFP values are observed in hepatocellular carcinoma or liver cancer and gonadal tumors as well. Haptoglobin is produced by liver cells. Its main function is to bind free hemoglobin that has been released from red blood cells. Increased levels of haptoglobin are seen in inflammatory processes, and it's used clinically to help evaluate rheumatic diseases. Haptoglobin, so increased levels will be seen in burns and nephrotic syndrome. Decreased levels can be seen in intravascular hemolysis. Ceruloplasma is a copper-containing protein and is synthesized in the liver. You will see an increased level in women, pregnancy, inflammatory processes, malignancies, oral contraceptive use as well. Wilson's disease is another thing that could happen from this, and this is characterized by low ceruloplasma levels. And this leads to copper deposition in the skin, liver, and brain. Alpha-2 macroglobulin, this is produced once again by the liver. Its function is to inhibit thrombin, which is a key enzyme in blood clotting. It's an increased levels are seen in nephrosis or nephrotic syndrome. Then we have transferrin. This is once again synthesized by the liver. Its function is to transport iron in the bloodstream. So about 33% of iron binding sites on transformin are normally saturated. In iron deficiency anemia, transferrin levels are normal or increased because the body tries to increase iron transport capacity. So it's trying to compensate for it, basically. Decreased transferrin levels can occur in people with liver disease or malnutrition. Complement fibrinogen in C-reactive protein. So complement is part of the immune system. Its activation results in cell lysis, which is the destruction of the target cells. Fibrinogen is seen as a band between beta and gamma globulins on plasma electrophoresis. It is an acute phase reactant, meaning its levels increase during inflammatory processes. C-reactive protein, or CRP, is produced in the liver. It is increased in response to inflammation. The CRP binds to bacteria and can help promote binding of the complement. And then this enhances phagocytosis by immune cells in a process called opsonization. CRP is going to be increased in acute rheumatic fever, bacterial infections, myocardial infarctions, rheumatoid arthritis, cancer, gout, and viral infections. So immunoglobulins, we have different ones of those, which I'm sure you have heard of before, but we have IgA, which is produced by your plasma cells. It is stimulated by the immune response to foreign particles and microorganisms. IgG is increased in liver disease, infections, and collagen disease. IgM will react with anti-A and anti-B blood group antibodies. So when you have a blood transfusion reaction, that's the one that's coming out. It's IgM, and reacts with rheumatoid factors and heterophile antibodies. And we have IgD, which is increased in infections, liver disease, and connective tissue disorders. IgE is associated with allergic and anaphylactic reactions, and it's involved in allergies, asthma, and hay fever. Some miscellaneous proteins, we have myoglobin. This is the heme protein that's found in striated muscles and cardiac muscles. If muscle is damaged, myoglobin is released, which leads to an increased level in the blood. In an acute myocardial infarction, myoglobin increases within 1 to 3 hours and it will peak at 5 to 12 hours. If the level doubles within 1 to 2 hours of the initial value, it confirms the diagnosis of an acute myocardial infarction. This will serve as a marker for success or failure of a perfusion after thrombolytic therapy, and it can also be increased in muscular dystrophy and crushing injury of muscles. Troponin. This is a complex of 3 proteins that bind to striated muscles, so cardiac and skeletal. You have TNT, TNI, and TNC. So the cardiac isoforms are TNT and TNI. These will increase within 3 to 4 hours after myocardial damage. They'll peak at 10 to 24 hours and remain elevated for 10 to 14 days after. TNT is specific for the heart. Even a small amount of cardiac necrosis will result in an increase in TNT, which makes this extremely useful for the diagnosis of an MI. We're going to talk more about troponins and stuff in our cardiac chapter, but troponin I, or TNI, is a specific protein that's found in cardiac muscle, and that helps play a crucial role in your muscle contraction regulation. It is widely used as a biomarker for diagnosing cardiac injury, particularly myocardial infarctions. So some things to note, we have cardiac specificity. So TNI is highly specific to cardiac muscle, making it a reliable marker for detecting heart muscle damage. The kinetics of TNI, its increase in levels. The TNI levels begin to rise 3 to 6 hours after a myocardial injury. It will peak between 14 to 20 hours after, and then about 5 to 10 days later, the TNI level will return to baseline. For diagnostic values, the relative increase in TNI levels is usually greater than that of other markers like the CK-MB or myoglobin. Because of this, TNI is more sensitive and more specific for cardiac injury. So a lot of labs are kind of switching to this instead of doing like a CK-MB or something like that. Serial measurements. For accurate diagnosis, it is important to perform serial measurements. Blood samples should be taken every 3 to 8 hours over a period of 48 hours, and this helps to monitor any changes in the TNI level. For reference ranges, the reference range for troponin or TNT is less than 0.1. Elevated levels above this threshold typically indicate that there is a cardiac injury. So clinical importance of this, measuring TNI is essential for diagnosing acute myocardial infarction or a heart attack and assessing the extent of cardiac muscle damage. It can also help guide treatment decisions and monitor patient progress. Some sample requirements for this. So we have a preferred sample, which is serum, is generally preferred over plasma for protein analysis. Their interference of hemolysis can sometimes falsely increase protein levels. The stability for protein samples, they're generally stable for 30 days if they're stored at the refrigerator 2 to 4 degrees Celsius temp. Reference range for total protein at least for serum is 6.5 to 8.3 grams per deciliter. And then there are different analytical methods that are done or performed for this. The Cajal method, this is a reference method for protein quantification. It involves measuring nitrogen content as a proxy for protein concentration. We have refractometry, which measures the refractive index of a sample. The refractive index reflects the concentration of dissolved proteins. This method is quick, but it's not as specific. Then we have the Biuret method. This is the most commonly used method in clinical labs. So this is the one you'll probably see. Relies on the formation of a colored complex between proteins and copper ions in an alkaline solution. The intensity of the color produced is proportional to the protein concentration. The Biuret method, as mentioned earlier, you have cupric ions, which react with the peptide bonds in proteins under the alkaline condition. What it does then is there's a formation of a violet colored chelate complex. And the measurement is the intensity of the violet color is directly proportional to the protein concentration and is measured spectrophotometrically. The dye binding method, most serum proteins have the ability to bind dyes. The common dye that's used is the Comasi Brilliant Blue. This method is sensitive and is often used for protein quantification. Then we have serum protein electrophoresis, or SPE. So the procedure for this really is the serum is applied at the cathode end of the electrophoresis medium. The medium is then saturated with a buffer to maintain the pH. Electrodes are connected and an electrical current is passed through the medium to separate proteins, which are based on their charge and size. So the principle of this is essentially the serum proteins carry a negative charge at pH 8.6. And due to this charge, proteins can migrate towards the anode, which is the positive electrode. So the protein migration order, albumin migrates the farthest toward the anode, followed by alpha-1 globulins, then alpha-2 globulins, and then beta globulins, and then gamma immunoglobulins, which are, they migrate the least. So fixation, after migration, the support medium is placed in an acid solution to help fix the proteins to the medium for further staining and analysis. After separation, the medium is stained to visualize the protein bands. The stained medium is then scanned with the densitometer. The densitometer measures the area under each peak, which representing or helps to represent the relative quantity of each protein fraction. These peak areas are calculated as a percentage of the total protein. So just an important thing to remember, if plasma is used instead of serum, there will be an additional peak in beta-2 globulin region because of fibrinogen, which is not found in serum, it's only found in plasma.